Good afternoon, everyone. Thank you very much for joining our Bunzl TENA webinar today. My name is Maeve Fogarty. I am the Healthcare Development Manager with Bunzl Healthcare and Government, and I look after all the TENA range of products with Bunzl in the Republic of Ireland. Also on the call with me today, I'm delighted to announce we have two members of the Essity team, and they are Ian Daniels, who will hand over to you now in a moment. Ian is the Account Sales Executive with Essity, who I work very closely with managing the distribution of TENA in Ireland. And then our main presenter today, I'm delighted to announce we have Sarah Murray. Sarah is a clinical consultant with Essity, and some of you I'm sure will recognise her from previous webinars. At this point, I'd just like to obviously offer everybody a very warm welcome and thank you for taking time out of your busy schedules. We really appreciate that. And also a big welcome back to anyone who has been on our previous webinars to date. This is our second already, or this year in 2021. So without further ado, I would like to hand over to Ian Daniels. Over to you, Ian. Thank you.
Thank you so much, Maeve. Hi everyone, my name is Ian Daniels and I work in the TENA distribution channel here at Essity. On behalf of everyone at Essity, we're once again absolutely delighted to participate in this collaborative TENA webinar series alongside BCSS. In our opinion, they really do go from strength to strength, and with such important topics, we are very proud to be invited to present our products and solutions to all viewers today. So thank you again. This month's event is the management of bowel incontinence, and it's once again kindly presented by my colleague and clinical consultant, Sarah Murray. Sarah has tremendous and vast experience with our TENA brand, and as always, we'd like to thank Sarah for her valuable time today. So I'll now hand over to Sarah. I really hope you all enjoy the session, and thank you so much again.
Thank you, Maeve, and thank you, Ian. I'm really delighted to be here again to talk about a bit of a different subject from the last time I was here, looking at healthy bowels. We've titled this one Healthy Bowel in Adults because I think it's important to remember when we're thinking about a healthy bowel for children, it can be a very different situation. So this is really focusing in on adults and probably particularly older adults. But if any of you who are listening do look after children or have children in your care, there's some great information on the ERIC website that would help support the advice that we would give regarding children. So just looking a little bit at the agenda and the learning outcomes for today. So we're going to have a very brief look at what is a healthy bowel and what we can do to help us maintain a healthy bowel. Obviously, one of the consequences of not having a healthy bowel is fecal incontinence. So we'll look a little bit at the causes and assessment of fecal incontinence, and ultimately how we can manage any fecal incontinence or contain it. And then a few tips at the end just as to how we can, the advice that we can give again that really brings back into focus how to keep our bowels healthy. So if we start thinking about what's a healthy bowel, so a normal healthy bowel will open somewhere between 3 times a day up to 3 times a week. And again, that's in adults. We'd be looking ideally at a type 3 to 4 on a Bristol stool chart or a similar kind of comparison chart. And it's really important when we do talk about bowels, the consistency of the stools is not only considered but recorded, because it can make a big difference as to whether somebody would be considered to be constipated or not. And as we'll see later on, constipation is one of the main causes of fecal incontinence. When going to the toilet, we should be able to pass the stools without any pain, and at the end of it, we should have a feeling of a complete void, as if we've completely emptied our bowels. Usually our bowel habits are low during the night, so it's not classed particularly as normal to open your bowels at night. So if you have, or you are looking after people who are opening their bowels at night, then again that might be a symptom of perhaps constipation or something that really ideally could do with being investigated, as caring for somebody, particularly if they need containment of stools or fecal incontinence at night time, can be very disruptive. Our bowels are most active in the morning and after meals. So we usually say that the bowel kind of wakes up around about 4 o'clock in the morning and is at its most active until about 2 o'clock. When we talk about having a healthy bowel and good bowel habits, very often you'll hear people refer to something called the gastrocolic reflex. And that's the stimulus that we get, or the sensation that we need to open our bowels, that's been preceded by eating. So about 20 to 30 minutes after eating food is when it's at its strongest. And when we're looking to advise people who may find it difficult to access a toilet or to open their bowels when they are sat on the toilet, using the gastrocolic reflex can be a real help. We know that then that's when most people are most likely to have the sensation, and we also know that it's strongest in the morning. So if you join the gastrocolic reflex with the fact that our bowels are most active in the morning, then the ideal time for somebody to open their bowels would be about 20 minutes, half an hour after breakfast. So what will improve our bowel health and what doesn't? And these are just things really just to take into consideration, because they're not always directly linked with what we might think of when we think about improving bowel health. So for example, keeping active, being physically active. We know that exercise can increase our bowel function and the amount of time it takes the food to move through the bowel and keep the bowel active almost. Whereas reduced mobility or immobility will slow our bowels down a little bit and can be a trigger factor again for constipation. Having regular meal times and having a good appetite also will help improve our bowel health, as opposed to people with poor appetite or reduced appetite, or perhaps people in their own homes if they're reliant on care or meals being prepared. It's important to know what people are eating or what they're not eating, especially when we're looking to see how often they are going to open their bowels. If we're not eating, we won't be passing as much stools, and therefore we could almost misdiagnose constipation sometimes. Having enough to drink, having a really good fluid intake, it's important for just health in general, and particularly for an older person. But we know that when it comes to keeping our stools in that type 3 to 4, it's really important that we've got enough fluid. When bowels are sitting in our large bowel and in our rectum, then the body will draw the moisture out of it. And if we're not replacing that moisture or that fluid by drinking plenty, then the stool themselves is at risk of becoming hard and impacted. And lastly, having toilet facilities that are clean, that are private, that are acceptable, to the individual that's having to use them. I've been doing this job for quite a long time, and when we first did training sessions around continence, we used to have a whole section on toilet acceptability. And I remember asking the question at lots of training days about toilets. And if I was in a care home, I would say, can I use your toilet? And if I was directed to the staff toilet, I would always say, no, it's fine, I'll use the resident's toilet, I'm not bothered. And very often they'd look at me with horror and kind of say, no, you don't want to use those. I wouldn't use the resident's toilet. And that would be my kind of trigger, really. I'd think to myself, you've walked into that one, because if you wouldn't use it, how can you expect anybody else to use it? So toilet acceptability should be everyone's concern. Doesn't matter what pay grade you are or what job you're doing. If you're looking at a toilet thinking you wouldn't use it, then don't expect anybody else to use it. And if there's somebody else that can come along and clean it, that's great. But personally, I just used to roll my sleeves up, get on with it and clean the toilet, so that I knew the person who was visiting would be able to use their time properly. The other things we need just to consider, skipping toilet visits as well, or if people are being toileted to routines that perhaps don't fit in with what we've just mentioned about the gastrocolic reflex. So I think about schools. You know, children, they finish their lessons at midday, perhaps, then everybody gets to go to the toilet, then they go and have their lunch and go and run around, and then they get back into the classroom and they're expected to sit down quietly, when really, probably for most children, that's when they actually just do need to go to the toilet and open their bowels. Some medications obviously can constipate, so it's important to make sure that you're aware of what medication, particularly some of the stronger painkillers that people might be on, and taking that into account. Also, if people are on a laxative routine, again, people can become, sometimes they can be taking a little bit too much laxatives or too many different types of laxatives. And again, just keeping an eye on it to make sure that we are helping their bowel the stools to be maintained around about a 3 to 4 and easy to pass. And the last thing there is just considering oral health. And in that as well, I would consider people's dentures, making sure people have got their dentures, that they haven't got ulcers, that they're, that they are able to eat their meals comfortably without it causing them too much upset. I've just popped this one in because we mentioned hydration, and very often it can be very confusing and conflicting knowing how much fluid is the right amount of fluid for people to drink. There is a fluid matrix available that's been done based on a person's weight or an adult's weight, but for the very old or the very frail, it doesn't always, it sometimes will give you an amount that's a little bit too high for them. And especially coming up to the summer months, when we're always being encouraged to push as many fluids with people as we can, encouraging people to drink and have extra fluids like ice lollies and jellies to keep up their hydration levels. I think this poster that's been we've done in conjunction with Think Kidneys, sort of directing people to look at the colour of their urine. So if somebody's urine is very dark, potentially they're not drinking enough. So you need to be drinking to keep your kidneys safe somewhere between 1, 2 and 3. But for most people, just to make sure they're well enough hydrated, probably a 4 would be acceptable. But certainly it just helps to give a guidance really as to how much fluid you need to drink. So just a little bit of looking at the fecal incontinence. We've tried everything we can to keep our bowels healthy. We know that somewhere around about up to 1.4% of the total adult population will suffer with fecal incontinence. It can be really difficult to get accurate statistics around fecal incontinence because it is widely accepted to be underreported. And so we know that a lot of people are out there managing it by themselves without seeking help. And that's very often through embarrassment. It's not such an easy topic to discuss as perhaps urinary incontinence, but also fear of being discovered with regards to smells, and it just seems to cause a higher level of embarrassment for some people, meaning that they don't seek any help about it. However, we do know that up to half of all residents in care homes will be suffering from fecal incontinence of some degree. Unfortunately, fecal incontinence can sometimes also be in long-term care facilities, can also be associated with increased mortality. And so it's really important, regardless of how that person is presenting with the fecal incontinence, that we always look for red flags. These are some of the most common causes, but it's just important to say that any change in bowel habits should always be considered as potentially a red flag for other conditions. So as I mentioned before, constipation is one of the most common causes of fecal incontinence, and we'll look again in the next slide a little bit as to why that might be. But otherwise, things like if somebody has an episode of an infective type diarrhea, so maybe C. diff or norovirus, then that very much overwhelms the individual at the time and will cause fecal incontinence that may just be temporary. Fecal impaction, again, we'll look at in a little bit more detail further on. Bowel surgery, if you've had bowel surgery or you've had any damage to the sphincter or your pelvic floor, and although it's not a form of surgery, childbirth as well, we do see quite a relatively high incidence of fecal incontinence with ladies who have had to undergo a more traumatic delivery with their children. If they've had to have episiotomies or instruments, that can certainly lead to nerve damage and damage to the sphincters, which results in fecal incontinence either in the short term or longer term as we age. So neuropathic disorders, so things like multiple sclerosis, Parkinson's, stroke, anything that interrupts the messages going from the brain up to going from the bowel up to the brain can potentially impact on our ability to remain continent. And bowel conditions such as Crohn's or even IBS, anything really that could overwhelm somebody, particularly when they're old and frail. So it might be linked to dietary, it might be linked to, even in the hot weather, sometimes people can suffer from dehydration and they can have diarrhea. So anything that's going to overwhelm, particularly an older person, potentially can cause fecal incontinence if the bowel is involved. But it's important to remember that it may not be something physiological. And in a lot of cases, just as we would assess somebody with urinary incontinence for the functional causes, we need to do the same for people with fecal incontinence. So is it caused by their inability or lack of available care? And I can remember throughout the years I've worked for TENA, lots of questions from people who deliver home care asking how we can better manage people, because if they're having timed visits, say 9, 12, 4 and 8 at night, our bowels don't work in that kind of timed way, a timed pattern. We can sometimes hold on to our urine a little bit longer, and our bladders will sometimes almost fit into a timed routine, but our bowels will behave very differently. And so it can be really difficult to maintain somebody's fecal continence if there isn't the availability of care to get people to access the toilet when they need to go. And physical frailty, if somebody is sort of unable to sit comfortably on the toilet, you find sometimes people as they age, if they're losing a lot of their body fat and their skin condition, they can find it really quite uncomfortable to sit on a toilet. Or if they've got arthritis or other painful joints, just sitting sometimes in the right position and holding yourself in the right position to go can be quite difficult. And of course, people with dementia, it's really important to understand that particularly fecal incontinence for people with dementia is not usually due to the progression of the dementia until quite late in the disease. And so before that point, if somebody is up and walking around, particularly if they're continent of urine but is displaying symptoms of fecal incontinence, then it's likely to be something to do with either constipation or their symptoms, their psychological symptoms of dementia, even something as simple as forgetting that they need to go to the toilet. Our bowels work by stretch receptors. So when the stools are filling up our rectum, the rectum is stretching and sending up the message to the brain that stools are in the rectum and we need to open our bowels. Those messages are only sent on the initial stretch. So once the rectum has kind of accommodated the stools that are there, the messages will stop going up to the brain. So if somebody's memory is only lasting 2 or 3 minutes and they're a little bit old, they're in an unfamiliar place, by the time they stand up to find the toilet and start walking there, they could well have forgotten what it was they were needing to do. And so again, knowing people that you're looking after and some of the cues that they might demonstrate when they're incontinent feces can be really useful. So I mentioned before about constipation, and this just shows really how much a loaded rectum can impact on both the bladder, but also causing fecal incontinence. We know that when the rectum is loaded with the stools like it is for somebody who's constipated, that can cause bladder symptoms of needing to go more often, not having as long to get to the toilet. But also in an older person, the way that our rectum and our bowels are designed, they're not designed to have the constant weight of the stools in the rectum. And so what you can sometimes find is that the sphincter isn't able to keep shut and keep the stools in. And you'll find that very often people with constipation, they may just pass very small stools. Sometimes people call it almost rabbit droppings, or they may just leave a mark on their underwear or the pad. And that can quite quickly be classed as fecal incontinence, when actually it's just a symptom of their constipation. And if you can relieve their constipation, then you will also resolve their fecal incontinence. And if we take that a little stage further and think about when people can become impacted. So if people become constipated, the stool stays in the rectum, hardens and isn't passed, but you carry on eating, you carry on drinking, the digestive process continues and more stools are being made and formed. And what will happen is it's kind of like almost like a traffic jam of stools, so that it just keeps on, the body keeps on producing the stools, and while the stools are sat in the rectum and the large bowel, all the moisture is taken out of them, they become harder and harder to pass. When we finish with the digestive process and the food that we've eaten enters the large bowel, it's just a waste product at that point. We've digested everything that we need, and it's quite watery, it's quite loose. And as it travels through the large bowel, as you can see the kind of up and down part of this picture, it becomes more and more solid. But if we carry on making that very watery stool and the waste product, and the rest of the bowel is impacted with stools, then that will leak past the hardened stool, and eventually, for some people, they will be unable to control it, and they will pass faecal fluid, like a type 7 on the Bristol stool scale, and that can very often be misinterpreted, particularly with children, as a diarrhea rather than a consequence of the impaction. So it's really important that we keep accurate records around people when they're opening the bowels, the amount that they are passing, and the consistency of the stool, as we mentioned earlier. So if we think about having to, we've assessed somebody who's has symptoms. If we assess somebody who has symptoms of fecal incontinence, and we've excluded constipation, we've excluded all the other causes and things that could be treatable, we're probably ending up having to look at the best possible management. And the 5 steps that we put on there are all sort of almost part of the assessment process again. So a bowel management programme will consist of making sure that people aren't constipated, using that gastrocolic reflex, and encouraging regular toilet visits and the privacy and giving people the time to open their bowels in private. The picture, or the other picture on the screen, I was going to say to your right or your left, but I can't work out which way it would be when you're looking at it. But the picture there you can see on the screen of the correct toilet position is really important. The way, again, that our bodies are designed, we have something called the anorectal angle, which is designed to help us maintain continence. And it's kind of like an S shape, almost like a U bend in the bowel. When we want to open our bowels fully, we need that to flatten out a little bit. And the best way to do that is to make sure that our hips are above our knees, almost in a squatting position. Sometimes, particularly with children, it can help if you get people to rock backwards and forwards, but again, it can help for some adults as well. But certainly making sure when people are sitting on the toilet, they've got their feet on something so they're not dangling, so they're well balanced, they are as relaxed as possible, but with their knees slightly higher, will mean that they've got the best chance of being able to open their bowels. If you do need to contain fecal incontinence, very often the first line is pads. The TENA range of pads are all designed to absorb urine. However, they will all contain faeces as well. And so just as you would do an assessment for the most appropriate pad for somebody's urinary incontinence, we'd recommend you do the same for somebody's fecal incontinence. So it may be that a shaped pad is enough to contain it. It might even be that a TENA men, placed in the back of somebody's underwear will just be enough to contain the fecal incontinence if it's only small amounts. But then if somebody is incontinent of larger amounts of faeces, you may need an all-in-one type product, the TENA Flex or even the TENA Slip. There are other devices that are out there. There's not lots to choose from, but there are some other devices. There is the one in the blue box is the fecal collection system, which is almost like a modified stoma bag. So it would be used on somebody who had very liquid stool, probably was being nursed in bed, predominantly on their side, and the bag is like kind of folded over and placed in between the buttocks to kind of contain around the anus. So with the idea that the faeces pass directly into the bag and reduce the amount of that it's coming into contact with the skin. The two, the one in the above the green box and the one to the side of the green box are both examples of anal irrigation systems. So Peristine was the first one that certainly I became aware of, but there are other brands out there now. And they are a way of irrigating your bowel to remove any stools that are in there as part of a longer programme of bowel management. I think these potentially get used a little bit more with children and young adults who suffer from sort of intractable constipation that really have very slow moving bowels because of neurological conditions. But for adults, again, if you've got something like multiple sclerosis or some of the neurological conditions, then these devices can be really useful. And at the bottom in the green box is the anal plug, and that's just exactly as it sounds. You've probably come across them. So it's like a small tampon type device that gets inserted into the anus, and as the moisture hits the device, it will open it up into a cup shape, and then it will contain any fecal leakage. A thing to be aware of, really, particularly with the anal plug, is that people will if you have normal sensation in your rectum and your anus, then that sensation you will have the sensation of something being present, and some people find that they can't tolerate that, they find it really difficult to use. Some people will say that actually that sensation is a better alternative to being fecally incontinent. But I attended some training recently where a continence nurse specialist recommended the use of like a lignocaine type gel, so a local anaesthetic gel to numb the area so that it makes it a little bit easier to tolerate. And if you can't keep the faeces off the skin, then really one of the most important things that you can do when you're thinking about containing people's fecal incontinence is making sure that we're providing good skin care. Urine and faeces, they both contain many skin irritants and will affect the skin's pH. So our skin pH likes to be around about 4.5. If you increase that skin's pH, it becomes much more prone to damage. Urine against the skin will do that, but when urine and faeces mix, the skin's pH will be raised, and the fecal enzymes, so our digestive enzymes that are present within stools when we void or pass them out are more active at a higher pH. And so just as they would digest your meals, they will start to work on your skin and can break it down. They estimate that an episode of skin damage can occur with as little as 2 minutes of faeces being in contact with the skin. So it's really important that we have a good routine in place. With older people as well, we know that soap and water can be really quite damaging to the perineal area. It can dry their skin out, and repeated rubbing, particularly if they've had episodes of diarrhea and their skin is quite excoriated and sore, can also cause increased pain. And actually the NICE guidelines, which for fecal incontinence, recommend when people are incontinent of faeces that a no-rinse cleanser is being used. So having some kind of protocol in place with a no-rinse cleanser. So we've got the wash cream, the TENA post-skin wash cream, which is a 3-in-1 cleanser to cleanse, protect and restore the skin. Can make a big difference when we're looking after individuals who have repeated episodes of fecal incontinence. If somebody is soiled and there is any fecal matter there, then we recommend using something like toilet tissue or a damp wipe just to remove that. But once you've cleaned the skin of any fecal matter, it's a very simple process then to just wipe the skin with the wash cream. It reduces the amount of rubbing and also leaves a nice restoring layer of moisture on the skin. So in summary, just the things to remember: making sure that people achieve a balanced diet and have an adequate fluid intake. There's lots of guidance out there about how much fluid you should eat and what foods are higher in fluid. In fibre. Getting confused with words there. So there's lots of things out there that you can access, and dietitians are a really great source of information for this kind of guidance, really, where you're looking at what is the best diet for somebody, particularly if they aren't able to serve themselves a balanced diet. And all the other things that we've talked about around the toilet, so making sure that it's clean, that it's they are sitting properly on the toilet, and that they are given the opportunity to go to the toilet and given the time. Keep in mind the gastrocolic reflex, so that when you are taking people to the toilet, you've got that extra sort of help and the extra stimulus that will provide. And make sure that it isn't just the medication that they're taking that's causing the issues. So just a quote really to leave you with, to think about the importance of promoting a healthy bowel for the people that we're looking after and for ourselves. We know that bowel care is often overlooked, and the quality of life, or the impacts of the quality of life that fecal incontinence or poor bowel care can be monumental, really, for some people. It's underreported, and when people do report it, they find it's an embarrassing condition to have to talk about. So we need to make sure we're doing everything we can to promote people's bowels to be healthy, and make sure that we are offering them every opportunity to seek treatment and management that suits them, so that they don't find that they are in a situation where their social life, they're becoming isolated, or the quality of life in general is being reduced due to fecal incontinence or poor bowel management. I think that was all I wanted to say, really. So I hope that's been useful, and I'd just like to hand you back to Maeve. Thank you.
Thanks very much, Sarah. That was an excellent presentation, as always. Some really interesting facts and some really good practical tips pertaining to bowel health. I think it's food for thought for everybody on the call today. So thanks again for that, Sarah. Obviously, a big thank you to everybody who joined the webinar this afternoon. As I say, I know you all have busy schedules, so we really appreciate that. Thanks again for your time. With regards to any questions or any updates or follow-ups from today, please feel free to pick up the phone or to email me. You always have my email contact details on the original invite. But if you don't, please just call into the Bunzl head office, and they can pass on my details, my contact number as well. We look forward to having you again at our next session. We're planning to host our next webinar in September. So please watch this space, and we'll be advertising that again very soon. Hope you all have a lovely afternoon. Thanks again. Take care. Bye.